Hi everyone, my name is Josie Acuña and I'm from the University of Arizona. I'll be giving this lecture along with Dr. Srikar Adhikari. This is Into the Wild, Ultrasound Beyond the Emergency Department. I'd like to quickly go over the objectives of this lecture. By the end of the lecture, you should be able to describe how to incorporate high-yield ultrasound applications efficiently into a variety of scenarios encountered in the wilderness. You should be able to demonstrate awareness of use of ultrasound in the management of rattlesnake bites, high-altitude illness, traumas, and musculoskeletal injuries. You should be able to recognize the benefits of using ultrasound in management of patients in resource-limited settings and understand the pearls and pitfalls of ultrasound applications in the wilderness setting. Now, mixed in with this lecture are a few basic tips for those of you into wilderness medicine who want to incorporate ultrasound into your practice. So tip number one is the standard ultrasound bottles are way too big for carry-on. TSA will take them away, so if you plan on bringing a handheld ultrasound along with some gel, be aware you're probably going to have to check these or bring a smaller size bottle, which is probably not going to be enough gel. Now, why ultrasound? Many of you listening might already be ultrasound enthusiasts, so this likely goes without saying. But ultrasound is non-invasive, it's reliable, it's repeatable. You can perform an initial exam and then repeat it to track changes and to track the evolution of a pathological process. And relative to other imaging modalities, it's actually very inexpensive. Now, I want to spend a couple minutes to talk about handheld ultrasounds. The increasing prevalence of these little portable devices has really encouraged a wider adoption of ultrasound among providers. They're lightweight, they're user-friendly, they're inexpensive. A recent review article on ultrasound in austere environments had this nice table of a few of the currently available handhelds out on the market and some of their features. You might find that some of these are pretty popular. You might already be familiar with a couple of these. The pricing, as you'll see, varies. However, they're still infinitely cheaper than the standard cart-based systems that you probably have in your department. And you can also see how their small size and weight make them optimal for travel and carrying around. The article I took this from is actually a review of a lot of what I'm going to be mentioning in my part of the presentation. So I'm including the QR code down here at the bottom right so you can check out this article for yourself and if you want to go a little more in depth on this table of handhelds. All right, so the first scenario we're going to discuss is high altitude sickness. High altitude travel, it's rather common. It includes anything from your basic ski resorts all the way to mountaineering. Acute mountain sickness can affect people who ascend even moderate altitudes. But I'm going to talk about how ultrasound can be used for high altitude pulmonary edema, HAPE, and high altitude cerebral edema, HACE, which are less common but significantly more life-threatening, right? So the primary treatment for these serious conditions involves descent, administration of oxygen, and pharmacologic management such as acetazolamide or steroids. So to have another modality such as ultrasound readily available on site to diagnose and monitor these conditions and to help guide your management, it's really a game changer. Now to dive a little bit deeper into HAPE, the primary characteristic of HAPE is pulmonary edema. As fluid within the lung increases, we start to see these vertical hyperechoic lines that drop down from the pleural line. These, as you might know, are classically known as B lines. And just to go into a little bit of the data behind this, I wanted to present this older but novel paper at the time done by Fagenholz et al. This study was able to demonstrate that ultrasound can be an effective diagnostic and monitoring tool for HAPE. In this study, they created a 28-zone technique where they ultrasounded the lungs and came up with what they call the B-line score. The higher the B-line score, they found actually correlated with lower O2 sats in patients that were clinically suspected of having HAPE. The next reference I have down here is a study by Yang et al. This was done much later in 2018, but this was a prospective study that determined the feasibility of using lung ultrasound for the diagnosis of HAPE. This was the first study that was done that actually investigated whether ultrasound is superior to a routine physical exam or a chest x-ray for the diagnosis of HAPE, and overall it was found to be a reliable method. Here's an example of the B lines I was just discussing in a patient with pulmonary edema. Again, we see these hyperechoic lines that extend from the pleura all the way down to the bottom of the screen. Now note this one was done with the curvilinear probe. This next clip was actually done with the phased array probe, and this is just to show you that this exam can be done with different probes, because with your handheld or whatever machine you have, you might not have all of the probes available. Some people may only be equipped with the phased array, some people with the linear, curvilinear. In either case, you should be able to perform this exam with whatever probe you have readily available. So as the disease process in HAPE progresses, you start to see these B lines become more numerous and congested, as you see here. You can actually see that some of the B lines are actually coming together to form much larger, thicker B lines. And this is just, again, a sign of progression of the disease. Now, there's much less data in regards to ultrasound for use in HACE. This particular article looked at the use of ocular ultrasound to diagnose and monitor HACE patients. They found that an increase in the optic nerve sheath diameter correlated with worsening altered mental status in these patients suspected to have this condition. A standard approach was taken in the study to measure the optic nerve sheath diameter just using a linear probe, measuring this sheath at the typical 3 millimeter depth from the posterior aspect of the globe. So theoretically, it seems that the optic nerve sheath could be used to evaluate increased intracranial pressure in HACE patients or patients suspected of having this condition, although this has not been specifically studied, but hopefully we can see more data on this in the future. Our next quick tip is that gel can freeze. So keep this in mind, especially when you're traveling to high altitudes, low temperatures. Find a way to protect your gel and keep it warm so it doesn't freeze. So next we're going to talk about trauma, probably the most commonly encountered scenario in wilderness medicine. And we're going to go over a few topics such as foreign body, fracture, dislocation, pneumothorax, and how ultrasound can assist your diagnostics and your management. Using ultrasound for foreign body, it's pretty straightforward. Large pieces of organic material can definitely be seen, such as this large splinter being removed under ultrasound guidance here on this image. Cactus spines as well can also be visible depending on their size. But be aware that sometimes you might only be able to see the hypoechoic tract where the foreign body has actually penetrated. I also want to talk about fractures. So ultrasound can be used to detect fractures, particularly of importance on site in remote locations, because given the location of the fracture and the extent of the injury, it can guide you in making a decision to plan an extraction. Many of us might not be particularly comfortable with ultrasound for fractures, especially because most of us come from larger emergency departments where X-ray is usually the mainstay and is fairly readily available. But the technique you'll find is actually pretty straightforward. You use a linear high-frequency probe. You normally want to scan in multiple planes, but to start, it's always helpful to place that probe parallel to the long axis of the bone. And it's helpful to also start at the point of maximal tenderness, as this is often going to correspond to the fracture site. As you're scanning through, you're just going to be looking for irregularities in the hyperechoic cortex, such as the small one you see here that's going by in the middle of the screen. And just for a little repetition, here is a break in the cortex, not as subtle as the last one. Sometimes you can even see a little anechoic hematoma that can be subtle but can be present over the cortex, and that can help guide you to where perhaps the fracture is. This is an example of a rib fracture, which is something that's pretty commonly encountered and easily able to be diagnosed using ultrasound. Along the same lines, I want to talk about dislocations, particularly shoulder dislocations. The data behind this is really great. I wanted to present the data from this paper by Acuña et al. And then found this awesome infographic from Gel that's already done this. So this was a prospective study that looked at how well ultrasound could diagnose shoulder dislocation. They found it to be 100% sensitive, 100% specific for diagnosing a dislocation. And of course, it can also help guide your reductions. The linear or curvilinear probe can be used to perform this study. In short, you want to locate the humeral head. Locating the humeral head is key. Once you find it, you just want to slide laterally to view the glenohumeral joint. Shown here in this image is actually an image of a normal joint with the humeral head within the joint space. Now here's an image of an anterior dislocation with the humeral head out of the joint space. Another traumatic scenario that is commonly encountered is pneumothorax. Ultrasound for pneumothorax has a sensitivity that's approaching 100% and specificity that's greater than 90%. To perform this exam, we identify 2 ribs with their rib shadows posteriorly. Then we identify the hyperechoic pleural line that's in between. In normal lung, the visceral pleura slides with respect to the parietal pleura. And this occurs during respiration. And we can visualize this lung sliding by looking at the movement within the pleural line. And we can also track this using M-mode, which tracks motion over time. This gives us this classic seashore sign that you see here on the right. You can look at the motionless chest wall above this hyperechoic pleural line in the middle, and then the sliding structures beneath the pleura. Whereas with pneumothorax, there's air between the visceral and parietal pleura, so we don't get that sliding we saw in the last image. And on M-mode, we see loss of that seashore sign, and instead we have no movement that's tracked over time. Now, of course, we are talking about trauma, so I have to bring up the FAST exam. There's a relatively large amount of data on the FAST exam. And EFAST allows for field providers to make an early diagnosis and potentially intervene in the field with needle decompression for pneumothorax, pericardiocentesis for pericardial effusion, or prioritize a more aggressive evacuation plan by making a rapid diagnosis. This study that I have listed under here by Blavis et al. Done in 2005 was done in the Amazon jungle. I just want to talk about this a little bit. So 25 patients were scanned during a medical missions trip, doing the FAST exam and abdominal scans, and this actually helped change the disposition of 7 out of the 25 patients that were scanned, including 4 that actually avoided evacuation based on the results of their ultrasound examinations. The basic views of the FAST are the right upper quadrant, left upper quadrant, pelvic, and subxiphoid. And EFAST is something we mention oftentimes too, and this is the same views with the addition of 2 apical thoracic views to assess for pneumothorax. And this is just an example of what free fluid looks like. So free fluid is going to collect within these dependent areas of the abdomen that we scan. On the right, we're seeing a stripe of anechoic fluid that's at the liver tip and within Morrison's pouch. And on the left side, we just have a scan of a negative right upper quadrant scan. My last tip for you is to remember that some of these handhelds operate off of iPhones and Samsungs now, so just be aware of this for technical complications. Know that your handheld can malfunction in extremes of heat. Being from Arizona, I often see this on my phone if I'm outside for too long. There's a temperature alert that actually prevents you from using your phone until it is cooled down. Again, just one more thing to keep in mind. So that's my end of this presentation. Next up, we have some more wilderness ultrasound scenarios with Dr. Adhikari. Thank you.